Maternal healthcare in rural Zambia, depicted in the short film, underscores the stark realities that women in resource poor settings encounter when giving birth. The film demonstrates how the limited healthcare infrastructure and supplies in these areas put maternal outcomes at risk. As a mother, it was challenging to envision the experience of childbirth in such dire circumstances, where fundamental necessities were in short supply. I also felt empathetic and appreciative of the healthcare professionals who exhibited resilience in their efforts to provide the highest quality of care given the limited resources at their disposal to innovate. My decision for choosing this case study is based on my understanding of the global issues of healthcare access. Research presents that maternal outcomes are significantly influenced by disparities in healthcare services, which frequently exacerbate in regions with inadequate resources. The film is also in alignment with my apprehension regarding reproductive health, which is particularly vulnerable in environments. After all, not only does inadequate access to care undermine the health of mothers and infants, but it also impedes the advancement of sustainable development objectives. The Australian Institute of Health and Welfare discusses that Australia employs nearly 1,000 maternal care models. Among these models, the midwifery group practice MGP and maternal led model can be employed in the particular community in Zambia, as these models prioritize continuity of care, ensuring that the same midwife provides support to women during pregnancy, birth, and postpartum. The implementation of midwife led models, however, is impeded by the persistent obstacles in the African region, such as traditional hierarchies, gender disparities, and effective leadership that impede its full integration. As for other international models of care, they emphasize collaboration and interdependence, like the women centered Nordic model used in Sweden and Iceland. Similarly, the Women with Midwives model focuses on building strong partnerships between women and midwives. This could be a probable option for increasing health seeking behaviors in women. Thus, given the immense involvement of midwives in maternal health, midwifery should also be greatly invested in communities. The improvement of midwifery practice then should spring from its education. With a lack of positions globally, it has resulted in many practices to evolve and adopt similar functions, such as the development of nurse practitioners to cover for the lack of primary care positions. Given this, there should be also structured practice to increase the knowledge and skills of midwives on emergent and complex obstetric practice through postgraduate programs or even short trainings. In Zambia and many regions of the world, pregnant women feel more comfortable with traditions. Therefore, encouraging and integrating present traditional birth assistance into the maternal health system is necessary in order for newer and safer maternal practices to be carried out. Lastly, the maternal health is largely impacted by the families. Thus, family counseling is necessary and should be integrated in the midwifery practice.